Hi, I'm Yusuke Yamamoto, Hepatobiliary and Pancreatic Surgery Division, National Cancer Center Hospital, Tokyo, Japan. Today I'm going to talk about assessment of retroperitoneal fat infiltration of pancreatic ductal carcinoma by MDCT. Our objective is to develop the grading classification of the retroperitoneal fat infiltration of pancreatic carcinoma determined by MDCT. We investigate whether the grading classification is a useful predictor of surgical outcomes in patients with pancreatic carcinoma. The aim of this study is to develop the grading classification of the retroperitoneal fat infiltration of the pancreatic cancer determined by MDCT. The clinical records of 132 patients that underwent macroscopic curative pancreatic duodenectomy for pancreatic carcinoma between January 2004 and December 2008 were reviewed retrospectively. All MDCT images were evaluated by two independent reviewers who did not have access to the original interpretations or outcomes. Retroperitoneal fat infiltration was diagnosed when soft tissue strands or streaks in the retroperitoneal fat radiating from the tumor were seen between the tumor and major artery. We divided the degree of the retroperitoneal fat infiltration of the pancreatic cancer on MDCT into the following four grades. A tumor without retroperitoneal fat infiltration was classified as grade 0. A tumor with strand or streak structure radiating from the tumor and the length of the structure was less than 5 mm was classified as grade 1. A tumor with strand or streak structure radiating from the tumor without abutting the major artery and more than 5 mm of the structure in length was classified as grade 2. A tumor with streak structure radiating from the tumor and abutting to major arteries was classified as grade 3. 13% of grade 0, 56% of grade 1, 19% of grade 2, and 86% of grade 3 had pathological extrapancreatic nerve plexus invasion respectively. This figure shows the results of the survival analysis according to the grading classification. There were significant differences in the survival rate between grade 1 and 2 and grade 2 and 3 respectively. This figure shows the results of the survival analysis according to the grading classification among the 43 patients with pathological portal vein invasion. There was significant differences in the survival rate between grade 1 and 2. This table summarizes the univariate and multivariate analysis of prognostic factors associated with overall survival. Lymph node metastasis, positive surgical margin, and grade 2-3 retroperitoneal fat infiltration were independently associated with poor prognosis. This table shows the chi-square test and logistic regression model analyzing the 12 pathologic factors related with the degree of grade of retroperitoneal fat infiltration. Histological extrapancreatic nerve plexus invasion was only identified as independent factors associated with high incidence of grade 2-3 retroperitoneal fat infiltration. In conclusion, we divided the infiltrating pattern of the pancreatic carcinoma on preoperative MDCT into the four grades. This grade was significantly related with the incidence of extrapancreatic nerve plexus invasion and may be useful as a predictor for survival after pancreatic duodenectomy for pancreatic carcinoma. It is important to distinguish preoperative with the patients of grade 2 and 3 because of associating to significantly poor prognosis. Even when the portal vein and superior mesenteric vein were involved, grade 1 was associated with favorable survival after pancreatic duodenectomy with venous resection.